Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
We depend on iron. I mean, it's in our blood, our food. It's absolutely essential for life. But here's the twist, right? What happens when something so vital becomes incredibly dangerous?
It's a really critical question. It really unpacks the delicate balance of biology, doesn't it?
Absolutely. So today we're taking a deep dive into acute iron toxicity. Now, for a long time, serious cases in kids were a huge public health issue, but thankfully, those have actually dropped dramatically.
They have, thankfully.
Yet iron poisoning is still a critical concern, especially in intentional overdoses. We see this in adolescents and adults. So our mission today is to, cut through the noise and really explore the complex world of iron poisoning. We'll look at its surprising history, how prevention efforts totally changed things.
Right, the public health angle.
Exactly. And then the insidious way it works, how it hits multiple organs, how we diagnose it, and crucially, the role of its specific antidote, deferoxamine or DFO.
Yeah, so you'll walk away from this deep dive with, hopefully, a really comprehensive understanding of how this common element can turn into, well, a potent toxin. You'll get some surprising facts and critical insights.
Okay, so let's set the scene. Iron's been used therapeutically for thousands of years, right? Think about ancient remedies for anemia, things like that.
For sure.
But reports of it being toxic, causing fatalities, they only really started popping up in the mid-20th century. So what changed? Why did it suddenly become such a danger?
Well, what changed was really a significant widespread shift in exposure, especially for children. In the 1990s, tragically, iron poisoning became the leading cause of poisoning deaths among young kids in the USA.
Wow, the leading cause.
The leading cause, and the main culprit, easily accessible prenatal vitamins.
Oh, okay.
Yeah, they often contain substantial amounts of iron, which is great for pregnancy, but these vital medications ironically became a potential hazard in homes with curious toddlers.
And this is where the story takes a really hopeful turn, actually. It shows how public health can pivot and make a huge difference. What were those key steps they took?
It was a really concerted effort, mainly put in place around 1997. First, the FDA mandated warning labels on all iron salt products.
Big, clear label.
Yeah, prominently stating the dangers, especially to kids. Alongside that, there were major educational campaigns aimed at caregivers, doctors, pharmacists, raising awareness.
Right.
And third, and this is really key, the FDA brought in unit dosing, blister packaging requirements for prescriptions with more than 30 milligrams of elemental iron.
Basically making it much harder for a kid to get into a whole bottle.
Exactly. Much harder to access a large, dangerous amount all at once.
So the big question, did it work? What was the impact?
Well, the impact was nothing short of dramatic. Fatalities in kids under 6 in the U.S., they decreased significantly. We're talking from 29 deaths in the decade before these rules to only 1 death in the 5 years after.
That's incredible.
It really is. And even though the blister pack rule was later rescinded, due to a lawsuit in 2003, analyses suggest that initial big drop in serious poisonings has actually held steady. It's a huge, kind of quiet success story in public health.
That's genuinely amazing news for pediatric safety. But what about today? Is iron poisoning still something we worry about?
Oh, absolutely. While those severe pediatric cases are way down, thankfully, iron poisoning is definitely still a critical risk. It's particularly concerning among suicidal patients.
Intentional overdoses?
Exactly. Especially women of childbearing age, actually. They made up something like 28% of iron exposures in the U.S. back in 2013 among teens and older individuals. So it's still a very real, very serious problem in certain groups.
That's a sobering reminder. Okay, let's get into the core of it then. How does this element, something so vital for oxygen delivery, for energy production in our mitochondria, how does it suddenly become so destructive in an overdose?
It really all boils down to iron's fundamental chemistry, specifically its ability to easily accept and donate electrons. It's called its redox capacity.
Yeah. Think of it like a tiny battery, constantly charging and uncharging. That's vital for countless cell processes. But in an overdose, that very property goes haywire. Excess iron acts as a catalyst for a damaging chain reaction, the Haber-Weiss reaction,
Right.
which generates these highly reactive, incredibly damaging molecules called hydroxyl radicals.
Hydroxyl radicals. Sounds bad. What kind of damage do they actually cause inside the body?
They just unleash chaos, basically. They cause widespread oxidative stress. Think of it like internal rusting.
Okay.
This leads to something called lipid peroxidation, where the fatty parts of cell membranes, the cell walls, essentially go rancid and break down. It destroys the cells.
Wow.
And a critical point, the mitochondria, the cell's powerhouses, they're a primary target.
Right, where energy's made.
Exactly. So iron damages their internal structures, shuts down cellular respiration, and that directly contributes to the severe metabolic acidosis we often see.
We often hear about free iron in an overdose context. What exactly is that? Why is that the dangerous form? That's a really crucial concept. So normally, iron travels in our blood attached to a protein called transferrin. It's like a natural taxi service for iron.
Okay, a chiller.
Precisely. And usually, only about a third of the seats on this taxi are filled. But in an overdose, the system gets overwhelmed. All the transferrin taxis are full.
No more binding capacity.
Exactly. The iron binding capacity is exceeded. This leaves iron circulating unbound. That's the free or non-transferrin bound iron. And that's the highly reactive, unchecked stuff that causes widespread oxidative damage in organs throughout the body.
What's really striking is how it seems to attack different parts of the body systematically. It's not just random damage.
No, it's quite targeted in a way. It's like a multi-front assault. So first you've got the gastrointestinal or GI toxicity.
The stomach issues.
Right. The nausea, vomiting, abdominal pain, diarrhea that's from iron, directly irritating the gut lining. But in severe cases, those free radicals cause much deeper injury. You can get bleeding, ulcers, even parts of the gut dying off, which is called segmental gut infarction. And there's a unique delayed problem too, stricture formation. Weeks later, scarring from the initial injury can cause blockages, like at the stomach outlet.
And the liver. As the body's main processing plant, I imagine it takes a massive hit.
It absolutely does. The liver gets overwhelmed trying to process all this iron. It leads to a characteristic type of damage, hemorrhagic necrosis, especially in a specific zone, zone 1, near the incoming blood vessels. Plus more mitochondrial injury there too.
And severe liver damage can lead to
acute hepatic failure, liver failure. And unfortunately, that's a really poor prognostic sign. It means the chances of recovery are much lower.
And you mentioned circulatory shock earlier, often the cause of death.
Yes. Circulatory shock is the most common cause of death in severe iron poisoning. And it's not just one thing causing it, it's multifactorial.
Right.
You've got fluid loss from the GI tract from bleeding. You've got vasodilation where blood vessels widen inappropriately. And crucially, iron has a direct negative inotropic effect, meaning it directly weakens the heart muscle's ability to pump, like a failing engine. So low fluid, leaky pipes, and a weak pump, a recipe for shock.
You also flagged metabolic acidosis as a key critical feature. How does iron directly cause that, beyond just the shock?
Well, beyond the shock contributing, a primary mechanism is actually the hydrolysis of that unbound ferric iron, the Fe3+ ions.
Okay, a chemical reaction.
Yeah. Simply put, the free iron reacts with water in the body, and this reaction liberates protons, H+ ions, unbuffered acid basically. So it directly contributes to making the blood dangerously acidic. It's a direct chemical assault.
And blood clotting issues, coagulopathy, that's also in the mix?
It is, and it's typically biphasic, meaning it happens in 2 stages. There's an early, often reversible phase where clotting factors are temporarily depressed.
Okay.
And then a later phase, which is usually secondary to the severe liver damage, since the liver makes many clotting factors. Plus, free iron itself can directly inhibit thrombin formation, messing up the clotting cascade further.
So we understand the devastating effects. Let's zoom out again. How does the body handle iron normally at a chemical level? And what's the absolute key factor determining how sick someone gets from an overdose?
Okay, so normally iron absorption is complex. It's an active process, mainly in the upper small intestine. We only absorb about 2 to 10% of the iron in our diet, usually.
Right, it's tightly regulated.
Very tightly. But in an overdose, that oxidative damage iron causes to the gut lining. It disrupts this regulation. It basically punches holes, allowing for much more passive absorption of iron.
So way more gets in than usual.
Way more. And crucially, this is really key. The body has no efficient way to actively excrete excess iron. We lose tiny amounts through shedding skin cells and gut cells, but there's no direct excretion pathway like for, say, sodium through the kidneys.
So if the body can't get rid of it easily, what's a main predictor of how bad things will get?
It really comes down to one thing: the amount of elemental iron ingested. That's the key factor for predicting toxicity severity.
And are there known thresholds?
Yes, we have pretty well-established ranges. Toxic effects can start around 10 to 20 milligrams per kilogram of elemental iron. Potentially severe toxicity kicks in around 40 to 60 milligrams per kilogram.
And lethal doses.
Potentially lethal doses are estimated at 200 to 250 milligrams per kilogram. Though tragically, fatal doses as low as 1 gram, just 1,000 milligrams, have been reported in toddlers. It doesn't take much in a small child.
And when do we see the iron levels peak in the blood after someone takes it?
Peak concentrations usually hit somewhere between 2 to 6 hours after ingestion. It varies a bit depending on the type of iron tablet.
Okay.
But it's important to know that after about 12 hours, checking the serum iron level isn't as helpful because the iron has mostly moved out of the bloodstream and into the body's tissues by then.
So how do we use blood levels to gauge toxicity in that crucial early window, say 4 to 6 hours?
Those serum iron levels are really important then. Levels between 300 and 500 micrograms per deciliter usually means significant GI symptoms, maybe some modest systemic effects. Get up to 500 to 1,000 micrograms per deciliter, and you're looking at pronounced systemic toxicity, likely shock.
And above 1,000.
Above 1,000 micrograms per deciliter, unfortunately, correlates with significant morbidity and a high risk of mortality.
Now, this is important for treatment. Are there any weird interactions, any quirks with lab tests when someone's being treated for iron poisoning, especially with the antidote?
Yes, absolutely. Critical quirks clinicians need to know. The antidote, deferoxamine or DFO, directly interferes with the standard colorimetric lab tests for iron.
How so?
It can cause falsely low readings. So you might think the iron level's okay when it's actually dangerously high.
Oh, that's dangerous.
It is. That's why specialized tests like atomic absorption or plasma emission spectrophotometry are recommended for accurate iron levels during DFO therapy. Also another test, the total iron binding capacity, or TIBC, is basically useless here.
Why is that?
It can give falsely high readings after an iron overdose, so it doesn't reliably tell you anything about the severity or how much binding capacity is left.
Okay, good to know. Now, you mentioned classic clinical stages of iron poisoning earlier, but you also hinted it's not always a neat step-by-step thing.
Exactly. It's crucial to remember patients don't always follow the textbook perfectly. You have to evaluate each person individually. But the stages give a useful framework. Stage I is the gastrointestinal stage.
Right after ingestion.
Almost immediately. Nausea, vomiting, belly pain, diarrhea, that direct irritation effect. You can get bloody vomit or stool. And here's a key clinical rule of thumb. If someone, especially a child, hasn't had any GI symptoms, particularly vomiting, within the first 6 hours, it almost always rules out serious iron toxicity.
That's a really useful point. Okay, what's stage 2?
Stage 2 is the quiescent or latent stage. This typically falls between, say, 6 and 24 hours after ingestion.
Quiescent meaning quiet.
Kind of.
Yeah.
The GI symptoms might seem to get better, which can be incredibly misleading.
A false sense of security.
Precisely. It's not truly quiescent. The cellular damage, the mitochondrial poisoning, is still ongoing, silently. The patient might still be lethargic, have a fast heart rate, worsening acidosis, even if their stomach feels better. It's a very dangerous period.
And then things can escalate rapidly.
Yes, into stage 3, the shock stage. This usually hits either several hours after ingestion or can be delayed, maybe 12 to 24 hours later. This is where, as we said, the most common cause of death lies.
The multifactorial shock.
Exactly. The hypovolemia, the vasodilation, the weak heart pump, all leading to poor tissue perfusion, severe metabolic acidosis, potential CNS effects like lethargy or coma, and the coagulopathy we talked about.
And the liver damage comes next.
Typically, yes. Stage 4 is hepatotoxicity. Onset is usually 12 to 24 hours post-ingestion, but sometimes it can be delayed even 2 or 3 days out.
That's when the liver gets overwhelmed.
Right. Leading to that hemorrhagic periportal necrosis, the mitochondrial injury. And again, acute liver failure here is a very poor prognostic sign.
And finally, there's a much later stage.
Yes, stage V, gastrointestinal obstruction. This is rarer thankfully, and it's delayed developing maybe 2 to 8 weeks after the initial ingestion.
Weeks later. Wow.
Yeah, it's caused by scarring and stricture formation from that initial severe gut injury. Usually affects the pylorus, the exit of the stomach. So you'd suspect this if someone starts having persistent vomiting weeks after they seem to have recovered from the acute poisoning.
Okay, that covers the stages. Now, something you mentioned that was really fascinating is the link between iron, the antidote DFO, and specific infections.
Yes, this is a really critical point, often overlooked. Certain bacteria are ferrophilic. They love iron. They need it for growth and virulence, basically to become more dangerous.
So iron overload feeds them.
It can directly stimulate their virulence, yes. Yeah. But here's the twist. Deferoxamine, the antidote, itself acts as a siderophore,
Me too.
a molecule bacteria naturally use to scavenge iron. So the DFO iron complex, ferrioxamine, can actually substitute for the bacteria's own iron source, effectively feeding them and increasing their virulence.
Wow, so the treatment itself can potentially worsen certain infections?
It can foster their growth, yes. The most frequently reported bug is Yersinia enterocolytica. But others like Klebsiella, Vibrio, Aeromonas, even fungi like Mucorales have been implicated.
So what's the takeaway for managing patients?
If you suspect an infection in an iron-poisoned patient getting DFO, maybe they develop fever, worsening abdominal pain, bloody diarrhea, you need to start appropriate antibiotics promptly.
Yeah.
But critically, you should not stop the DFO chelation. The benefit of removing the iron outweighs the risk of fostering infection, provided you're also treating the infection aggressively.
Okay, that makes sense. So let's shift to management. Iron poisoning is suspected or confirmed. What's the immediate game plan?
First things first, stabilization is paramount. Assess airway, breathing, circulation of the ABCs, get off IV access established quickly.
Fluids are key.
Absolutely. Prompt 4V volume repletion, giving fluids, is crucial for anyone with significant toxicity to combat dehydration and shock. If the patient is lethargic or has altered mental status, early endotracheal intubation is often wise to protect their airway, especially if you're considering decontamination methods.
And who needs to go to the ICU?
Definitely anyone with significant acidemia, shock, altered mental status, GI hemorrhage. Also generally a serum iron, over 500 micrograms per deciliter at that 4-6 hour mark, or if x-rays show a lot of pills still in the gut, or if they need DFO or have significant liver issues, those patients belong in the ICU.
Okay. Now, decontamination. You mentioned activated charcoal doesn't work for iron. So what do you do to try and get the iron out of the gut?
Right, charcoal's out. Inducing vomiting isn't recommended either. They're often already vomiting and it's risky.
So stomach pumping, lavage.
Or a gastric lavage might be attempted, but really only within the first hour or so for potentially life-threatening ingestions, and frankly, its efficacy is questionable. Iron tablets can be sticky, large, and hard to get out that way.
So what's the main approach?
The mainstay, especially if x-rays show tablets still visible in the GI tract, is considered whole bowel irrigation, WBI.
What does that involve?
It involves giving large volumes of a special polyethylene glycol electrolyte solution, often through a nasogastric tube, to basically flush everything through the intestines quickly.
Okay. And if even that doesn't work, for really bad cases?
In truly life-threatening situations, if there's a persistent mass of iron tablets seen on x-ray despite WBI, then more invasive methods like upper endoscopy to physically remove them, or even surgery, a gastrotomy to open the stomach, might rarely be considered.
All right, so you've stabilized, you've decontaminated as best you can. Now for the specific antidote, deferoxamine, DFO. Tell us about it. How does it work?
Okay, DFO. It's the parenteral chelator of choice, meaning given by injection, usually IV. It actually comes from a bacterium, Streptomyces pilosus, discovered back in 1964.
Wow, been around a while.
It has. Early animal studies and clinical reports came out quickly in the mid-60s and early 70s showing it worked. But it's important to understand, unlike modern drugs, there haven't been large randomized controlled trials definitively proving its efficacy or figuring out the absolute optimal dosing for acute iron poisoning.
So current practice is based on?
Largely empirical. Decades of clinical experience, case series, and understanding its mechanism have led to the current recommendations. It works, but the protocols are built on history and observe success more than placebo-controlled trials.
So when do you pull the trigger and give DFO? What are the indications?
It's strongly recommended for anyone showing signs of moderate to severe systemic toxicity. That means things like repetitive vomiting, looking really sick or toxic, lethargy, confusion, low blood pressure, or shock.
Get to stage 3 stuff.
Exactly. And especially metabolic acidosis. A high Anning gap acidosis with elevated lactate is a really strong sign of significant cellular iron poisoning. and a clear indication for DFO. GI bleeding, significant liver problems also warrant it.
What about the iron level itself?
A serum iron concentration of 500 micrograms per deciliter or higher, measured at that 4 to 6 hour window, is generally considered an indication. But, and this is critical, you should not withhold DFO just to wait for an iron level if the patient is clearly significantly poisoned clinically.
Why not?
Because early administration is crucial. You want DFO on board quickly to chelate that dangerous free iron before it causes irreversible tissue damage. Time matters.
Okay, so how does it chemically grab the iron?
DFO is what's called a hexadentate chelator. Think of it like having 6 claws perfectly shaped to grab onto ferric iron F3+Ys. It has a very strong affinity and specificity for it.
Binds it tightly.
Very tightly, in a 1-to-1 ratio, forming a stable water-soluble complex called ferrioxamin. This complex is then mostly excreted by the kidneys.
And what iron does it target?
Its main action is grabbing that non-transferrin-bound free iron in the serum and also some weakly bound iron inside cells, preventing that mitochondrial damage. Importantly, it does not pull significant amounts of iron off transferrin or out of hemoglobin or essential cytochromes. It targets the toxic excess.
What about its pharmacokinetics, how it moves through the body?
It's poorly absorbed if you take it by mouth, which is why the IV route is preferred for acute poisoning. It distributes quickly, within 5–10 minutes, and its elimination half-life is around 3 hours.
And excretion.
Both DFO itself and the ferrioxamin complex are mainly excreted by the kidneys, and they can be removed by hemodialysis, which is important for patients in kidney failure.
Are there special populations to consider? Pregnancy? Kidney failure?
Yes. For pregnancy, DFO is generally considered safe if the mother has serious iron poisoning. It's unlikely to cross the placenta in large amounts, and stabilizing the mother is the best thing for the fetus. Suspending breastfeeding during treatment is usually prudent, though. And as mentioned, in kidney failure, DFO should ideally be given in conjunction with hemodialysis to help remove the ferrioxamin complex that builds up.
So you've started DFO. How do you know when to stop? And what about that famous Vinrose urine color? Is that still the guide?
Okay, stopping DFO. The primary guide should be clinical improvement. Is the patient looking better, alert? Are their vital signs stable? And critically, has the metabolic acidosis resolved? That's considered a reliable and recommended endpoint.
And the Vinrose urine, that pinkish red color?
Yeah, historically that was used. The color comes from the ferrioxamin being excreted, but it's no longer recommended as a reliable indicator for starting or stopping therapy.
Why not?
Well, its absence doesn't rule out severe poisoning, especially if kidney function is poor. And there's really no established link between the amount of iron excreted in urine or the intensity of the color and how well the patient is actually doing clinically. The guideline now is often to continue until the urine color stops changing, but rely mainly on clinical status and acidosis resolution.
How long do people typically need DFO? Are there risks with long infusions?
Most patients usually require less than 48 hours of DFO infusion. There's a known risk associated with prolonged continuous infusions, specifically longer than 24 hours, which is acute respiratory distress syndrome, ARDS, a serious lung injury.
So there's a time limit, ideally.
Yeah, you want to use it for the shortest effective duration. Other risks include hypotension, especially if it's infused too quickly, and that risk of Yersinia sepsis we talked about.
Beyond DFO, are there any other therapies out there, maybe experimental or for really extreme cases?
There are a few things. Some oral chelators, like deferasirox and deferoprone, are approved for chronic iron overload, like in thalassemia.
And not for acute poisoning.
Not really studied or recommended for acute toxicity. There are various concerns, including potential toxicity themselves or slow onset. Then there's extracorporeal removal, things like hemodialysis or hemofiltration. They can remove the ferrioxamin complex, which is especially useful if the patient has kidney failure.
What about exchange transfusion, swapping out the blood?
It's been suggested, mostly in severe pediatric cases, as a way to physically remove iron-laden red cells and free iron. But it's complex and carries risks, like potentially worsening hypotension. Not a common approach.
And surgery.
Very rare. But in those life-threatening cases with huge concretions or bezoars, solid masses of pills stuck in the stomach or bowel that aren't shifting with WBI, then yes, surgical removal via gastrotomy or bowel resection might be a last resort.
Wow. Okay, what a deep dive that was into the really fascinating, sometimes scary world of iron toxicology. We've gone from warning labels changing pediatric
A
safety
huge public health win.
to the microscopic chaos iron unleashes inside our cells, and then the targeted, life-saving intervention of DFO.
It really does highlight that critical balance of essential elements, doesn't it? And the complex ways things interact in our bodies. That quiescent phase we talked about is such a stark reminder. What looks stable on the surface can still hide ongoing, really dangerous toxicity.
A powerful lesson in looking deeper.
Definitely.
So, what does this all mean for you, our listener, taking this all in?
I think it's a powerful illustration of how medical science is constantly evolving, right? Understanding these complex threats, finding ways to counteract them, turning those scientific insights into treatments that actually save lives. It's a testament to inquiry and intervention, and sometimes just sheer observation over decades.
Absolutely. And maybe here's a final thought for you to chew on. We know so much about iron, yet its interactions, even the good ones, can have such unexpected and severe consequences when things go wrong, when the balance is tipped. It makes you wonder, what other common, maybe seemingly harmless elements or substances out there might have hidden dangers or complex biological roles we're only just beginning to fully grasp?
That's a great question to ponder. The body is incredibly complex.
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.